And doctor said, excuse me,
The only thing is that my my background is the other way around. Like I don't know how to fix that.
Okay.
It's all right. I think so.
Flip it from the different.
Yeah, I think I have to change the picture the opposite way.
No, we should mirror.
Yeah, it is a
mirror.
mirror. It is mirror image, but I don't know how to fix that.
No, that's fine. A Mega Online with you is fine.
It's all right.
Because you're not
It's doing
using
very
it.
well.
Right from left to right is the same.
Okay, we are going live now online now.
Yeah. Okay.
We are online now. Thank you.
Brilliant. Shall we start? Yes.
Just give me 1 second, please.
Okay.
1 second. Only 1 second.
I'm recording.
Yes, okay. Yes, recording. Yes, thank you very much, Dr. Anna. Just give me 1 second, please. Okay. Okay. Recording. Record this computer. Yes, please.
All right. Brilliant. First of all, I would like to thank all the panelists, all the speakers tonight, and I would like to welcome all our attendees from all over the world. Another fruitful night, wonderful night of the Mega Online course. Tonight we have extraordinary speakers. We have 2 wonderful lectures, and I'm sure that all of you will enjoy it. To start with, we have Professor Khalid Abdelhamid, Professor of Anesthesia and Pain Management in the National Cancer Institute in Cairo University. Professor Khalid is the current president of the Egyptian Society of Chronic Pain Physicians. He's the former head of Anesthesia and Pain Department at the National Cancer Institute in Cairo, and he's the founder of the Egyptian Society of Chronic Pain Physicians, which was founded in 2016. The society is very active since its establishment. It delivered 12 workshops and an international conference, which encouraged a new promising generation of physicians in the field of pain medicine. Tonight, Dr. Khalid will talk to us about the transition from acute to chronic post-operative pain. So with no further ado, I would like to welcome Dr. Khalid and give him the microphone.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Hi, everyone. At first, I am so glad to join and be one of the presenters of Mega Online course. I am so grateful to Professor Saad Mahdi for choosing me, and really I'm proud of his work and devotion and wishing him very good luck. Today, I will explain the role of anesthesiologists to help in prevention of transition of acute post-operative pain to a chronic one, which is so difficult to treat, as I will explain. Also, I will declare and discuss the importance of the concepts of multimodal and preventive analgesia and how to apply. During my presentation, I will put some questionnaires to clarify my messages and make them delivered easily. At first, I will summarize the drawbacks of inadequate post-operative analgesia. As we all know, the recumbent patient, because of pain, has high tendency to develop deep venous thrombosis, high tendency to develop pulmonary complications. He has delayed healing process, and also in oncological surgery, the metastatic lesions may be more than a patient with adequate analgesia, because inadequate analgesia lead to decreased immunity of the patient, and the malignant cell can settle in other sites and the patient develop metastasis easily. As I work in National Cancer Institute, I saw this many times. So we learn our followers that our fellows that laparoscopic oncological surgery equals epidural, catheter, and adequate analgesia. The most worst of them is the development of chronic post-surgical pain syndrome or situation. My first questionnaire, chronic pain is a continuous acute pain. Is it true or false? Really, it is a very false concept. Before we discuss it, we must define what's acute pain and what's chronic pain. Acute pain characterized by recent onset, predictable, more or less predictable duration, which is the duration of the healing process of the injury, and the cause is very clear to the physician. But chronic pain commonly persists beyond the time of healing. It has no cause. Obviously, you may see it is no cause. Why the patient is in pain? The operation is very good. The plates and the screw are in place. Why they are in pain? So it is important to differentiate between acute and chronic pain. Chronic pain commonly persists beyond the time of healing and the injury, and frequently you may not find any cause. The International Association of the Study of Pain define the chronic post-surgical pain as pain developed after a surgical procedure of at least 2 months duration, and the other causes have been excluded, like continuing malignancy or infection, and this must be excluded by proper workup. So if it fulfills this criteria, this is a case of chronic post-surgical pain. Why it has happened? Chronic post-surgical pain happens because there are many changes in the CNS, which is called the neural plasticity, which developed a new state of pain perception in the CNS, especially in the spinal cord lamina 2, which is the site of the relay between first order pain neuron and second order pain neuron. This neuroplasticity may be in form of increased receptive field, may be in form of activation of lambda receptors, may be in form of more production of stimulatory neurotransmitters. This will lead to a new state of the CNS. The CNS becomes sensitized, becomes always sending signals to the cortex that there is pain in that place or in another place, as I will explain. This slide is very important. If we start by surgery or injury, it is acute pain due to activation of the nociceptive fibers. But if this activation sustained for a time, it will sensitize nociceptor fibers. It becomes more sensitive than usual, becomes more sensitive than the intensity of the injury. And the patient complains of hyperalgesia. This state is a prolonged subacute pain. With continuity of this nociceptive impulses, the CNS will go into a new state of central sensitization or CNS neuroplasticity with structural remodeling, as I said, increased receptive field, activation of number receptors, and so on. And this is the chronic pain state, which is very difficult to treat if we reach this situation. It needs aggressive treatment. It needs multimodal treatment. So the chronic pain syndrome, especially post-operative chronic pain syndrome, must be treated by multimodal and multidisciplinary mode, pharmacological, non-pharmacological, interventional, and the psychological social. If we don't apply these modalities, you will not cure the patient with chronic post-surgical pain syndrome. It is so difficult. So it is very important for anesthesiologists to be aware of this and to try to treat acute post-operative pain adequately at all time in the early and late post-operative period to help in prevention of this catastrophic syndrome. The second questionnaire as all anesthesiologists, that the patient did surgery, so mild acute postoperative pain is acceptable. No, it is not allowed. Why it is not allowed? Because of this slide you saw before. So this slide explain what I mean. No, any acute postoperative pain is allowed for prolonged time. Try at any time, on all times, to ameliorate this pain and to prevent the development of chronic pain. The third questionnaire, chronic postoperative pain is not a common problem. Is it true or false? It is a common problem. As we see as pain physicians, we face every day many cases of chronic postoperative pain syndrome. In this study done 30 years ago in 10 UK hospital-based pain clinics, that 22.5% of cases attending this pain clinic have or had chronic post-surgery pain. It's a big percentage. It's 30 years ago. I think surgery at that time was not extensive like now. And now there is more extensive surgeries and more extensive trauma to the patient. In another Turkish study, in 2009, they determined the incidence of chronic pain in certain operations. Post-mastectomy, 20 to 50%, thoracotomy, hernia repair, amputation, cesarean section, hysterectomy, hip arthroplasty, coronary artery bypass graft, vasectomy, cholecystectomy, colectomy. And I increase the post-laminectomy syndrome, which we see every day, hundreds of cases every month after back surgeries and fixation and so on. Post-laminectomy syndrome is the most common, I think it is the most common chronic post-surgical pain syndrome. But this slide shows that we have a good percentage of chronic post-surgical pain in certain operations. The next questionnaire is chronic post-operative pain is almost always a responsibility of the surgeon. The surgeon is not well trained. He injures some tissues, he injures some nerves. He didn't know his way. This is maybe true, but he is not the only one responsible. The type of patient, the role of anesthesiology, and the type of operation, and the cleverness of the surgeon, and the awareness of the surgeon about this syndrome, these all factors share in production of chronic post-surgical pain syndrome, and awareness and the knowledge of these factors will decrease the incidence of chronic post-surgical pain syndrome. This sum of the putative risk factors for chronic post-surgical pain is very important. The preoperative factor, like psychological factor. Yes, the patient in depression or anxiety or schizophrenia is more vulnerable to have sustained acute post-operative pain and development of chronic post-surgical pain syndrome. Also, the pre-existing pain syndrome like fibromyalgia, headache, low back pain, irritable bowel syndrome, all these patients have centrally sensitization already. So they are very vulnerable to develop chronic post-surgical pain syndrome. The preoperative pain in the surgical site may share, and as we all know, the patients which will be subjected to amputation if they intubated before or the skin incision before proper analgesia, the patient very high risk of developing phantom pain and stump pain. It's very important, and many researches prove that fact. Also, the younger age group, the younger the patient, the more risk of developing post-surgical pain. Genetic and environmental components, because of every patient, every man, every human being has certain number of opioid receptors. If this opioid receptor number is low, he is very sensitive to pain and very subjective to chronic post-surgical pain syndrome, and vice versa. So the genetic and the environmental components is very important. Intraoperative factors like nerve handling and the injury, it is the surgeon fault. Okay. Type of incision, it is the operation fault. Is it laminectomy? Is it inguinal hernia repair? Is it thoracotomy? Is it sternotomy? Is it mastectomy? The type of incision can increase the incidence of that syndrome. Non-utilizing nerve-sparing techniques. The surgeon is not aware about, especially oncological surgeon. They do not, generally, they do not respect the tissue, including the nerves. Type of surgery, as I said, the location, some operations have higher incidence. Use of mesh in inguinal hernia, staples, sternal wire. The most important, and it is the anesthesiology fault, is inadequate management of acute post-operative pain, which our main job. As I discussed with Dr. Saad before the presentation, our job as an anesthesiologist is not to intubate the patient and make him sleep during surgery and then go away. He is not my patient. No. It is improving the outcome of surgery. The goal is the patient, is that the patient will be cured from his original disease and go home with no complication. So it is very important to adequately control acute post-operative pain. Maybe disease recurrence at surgical site because of pain and ignorance of treating such pain may lead to chronic post-surgical pain syndrome. And lastly, the use of chemotherapy or radiotherapy as the site of the operation will increase the damage and will lead to chronic post-surgical pain syndrome. And I saw this very frequently, especially with radiotherapy after thoracotomy for mesothelioma or bronchogenic carcinoma and so on. The patient is complaining of intercostal neuralgia because of radiotherapy after surgery. So beware about these all conditions. You have to put a strategy for every patient. For a patient doing mastectomy, for a patient doing thoracotomy, for a patient doing inguinal hernia repair. Every case is a distinct case. You must manage separately according to the understanding of the risks of developing such chronic pain syndrome. The next questionnaire is chronic post-operative pain is seen only in operations involving and or injuring part of peripheral and or central nervous system. Is it all neuropathic pain? No. This is not true. It may be due to somatic pain, soft tissue pain, bone pain. This is somatic. Psychological aspects must be respected. Myofascial pain syndromes in patients susceptible to that, like fibromyalgia and chronic fatigue syndrome, myofascial pain syndrome may develop pain after surgery. And it is a unique type of pain. It is very important. And lastly, the neuropathic pain due to either direct injury or another causes like phantom pain or sympathetically maintained pain like complex regional pain syndrome, which I mean reflex sympathetic dystrophy and causalgia. Somatic pain may be due to remaining primary pathology, like vascular disease, tissue damage from trauma, additional stress on affected and not affected joints and tissue, like due to altered biomechanics and overuse syndrome of remaining structures and tissue. So somatic pain is very important as a source of chronic post-surgical pain and the development of chronic post-surgical pain syndrome. You must search for. This slide is very important. It is the complex regional pain syndrome. It is a very common situation, not common, it is rare, but you have to, it is not uncommon, it's not rare. It is not uncommon, but you have to be aware of this. This patient, for example, do carpal tunnel syndrome. Is it normal after carpal tunnel syndrome, say 6 months after this operation, the limb become like that? No. It is swollen, it's painful, it is hot, it is red. This type of disability makes the surgeon thinking of deep venous thrombosis, no, these cellulitis, and so on, and they ignore the development of complex regional pain syndrome. So the anesthesiologist must be aware of this syndrome, and it is very important in such operation like carpal tunnel or arthroscopy knee, which may accompanied by nerve injury, to do adequate postoperative analgesia to decrease the incidence of developing such a lethal syndrome. Although there is a genetic predisposition to such syndrome, and you can take from the patient history, if you can, if the patient can inform you about that, especially in limb surgeries, it's very important. The next questionnaire, opioid alone can treat acute postoperative pain effectively. This is absolutely false. And the concept of multimodal analgesia was developed to decrease the need of opioids or to be opioid-free analgesia postoperative because of side effects of opioids like tolerance, like induced hyperalgesia, like nausea and vomiting, and so on. The concept of multimodal analgesia, simply you have to deal with the pain pathway at all steps by specific measures and the pharmacological agents, to use small amounts of every drug and to avoid the side effect, and to use minimal doses of opioids. So at the site of injury, opioids doesn't work. So you can do local anesthetic block. You have to use anti-inflammatory agents, COX-2 inhibitors. It's very important. Because if you have to treat pain, you must treat the origin of pain and the pathway of pain. What is the methods of treating pain at the origin? It is the local blocks and the anti-inflammatory drugs. If you can't do local blocks, you have to give non-steroidal anti-inflammatory drugs unless it is contraindicated. Then the first order neuron, the nerve, can be blocked by local anesthetic. So this is peripheral nerve block. Then in the spinal cord, lamina 2, the first order neuron will transmit pain signals to the second order neuron. This area of spinal cord, you can do spinal, you can do epidural, both epidural catheter by local anesthetics, opioids, alpha-2 agonists, and lambda antagonists like ketamine, alpha-2 agonists like clonidine, opioids like fentanyl, or preservative-free morphine, local anesthetics. So the epidural catheter is very important in prevention of or amelioration of acute postoperative pain, and must be used in cases selected. Then this is the pathway. It will cross to the opposite side in the spinothalamic tract and go to the brain. In the brain, what is work? Opioids can work in the brain. Alpha-2 agonists can work. Centrally acting analgesics, acetaminophen. You have to give acetaminophen, paracetamol, anti-inflammatory agents. So all these agents can be work on the cerebral cortex. So multimodal analgesia must be applied for every case of acute postoperative pain to minimize the use of opioids. And you have to do local blocks and central interruption of pain signals by your sense of as an anesthesiologist. Which opioid? Can we give fentanyl? Yes. Can we give morphine? Yes. Oxycodone? Yes. Mipridine is contraindicated. Now, in Egypt, we see all the anesthesiologists give mipridine, which is betadine in Egypt. This is a very bad opioid. It is asynthetic. It is very short acting, so you have to give it every 2 hours. High incidence of nausea and vomiting, high incidence of addiction, and the most worst is the degradation product of it, which is normipridine, which is neurotoxic and accumulated with repeated injection of betadine, and the patient may develop CNS toxicity in the form of convulsions. So please don't use mipridine or betadine literally. Use fentanyl, use morphine, oxycodone, now registered in Egypt and Bul. The next, preemptive analgesia is enough to deal with post-operative pain. It is a false idea and old idea that the analgesic dose of fentanyl or morphine just before intubation and before the skin incision is very helpful, and it is only satisfactory for prevention of post-operative pain, which is false. Now we have the concept of preventive analgesia. What is this concept? Preventive analgesia, including preemptive and other. Preventive is a strategy. Preventive must be preoperative, must be intraoperative, must be early postoperative and late postoperative. The preoperative, 3 or 4 days or 1 week before, we can give oral medications like anticonvulsants, pregabalin and gabapentin, which help in decrease of axonal transmission of pain signals later on when we develop a plasma level satisfactory to do this before surgery, and preemptive, which is just before the skin incision, is also part of the preoperative. So the preoperative must be start 3 or 1 week before operation, and the preemptive at the time of skin incision. Then intraoperative analgesia is very important. Don't rely on 1 ampoule of fentanyl 100 microgram given at induction and it will be okay for all the time of the operation, 3 or 4 hours. No, you have to monitor the patient for signs of inadequate analgesia and deal with it. You can give non-steroidal anti-inflammatory, you can give more opioids, you can give ketamine infusion, you can give local anesthetic at the site, intraoperative if you can. So it is very important. Also, the early post-operative, the first 24 hours, and the late post-operative in the rehabilitation period, especially in joint replacement and orthopedic surgery. It is very important the patient has no pain and early ambulation to prevent the development of chronic post-operative or post-surgical pain syndrome. Here, there is a meta-analysis of the use of the anticonvulsants like pregabalin and gabapentin in prevention of the chronic post-surgical pain syndrome, and it shows that pregabalin is more effective. Why pregabalin is more effective than gabapentin? Because the pregabalin bioavailability is easier to develop than gabapentin. Gabapentin, most of the drug which is taken orally, or the 2 drugs are taken orally, no IV preparation till now. So the pregabalin, which is Lyrica, the high bioavailability of Lyrica make the plasma level to reach the steady state in a shorter duration than the gabapentin. So if we start pregabalin 3 days before the operation, be sure you have sustained a plasma or a steady plasma level, but gabapentin needs more time. So it is recommended to use pregabalin. Also, as I said, ketamine as NAMDA antagonist is very important, but till now, the meta-analysis does not support that it is significantly reduced post-operative pain at any time. But personally, I use it and I found many advantages of using ketamine intraoperatively. Sure, you have to put the patient in patient-controlled analgesia, either electronic or disposable. The next questionnaire, we cannot anticipate and measure incidence of chronic post-operative pain. No, we have some trials of measuring and anticipating the incidence of chronic post-operative pain in some patients. Calcium pain reduction, which is developed 2008, put some criteria: 6, female take 1 point, male 0, age younger, as I said, take more points, pain before surgery at the site, if it is present, take points, regular use of opioid 1 point, regular use of anxiolytic antidepressants 1 point, open surgery it's 1 point, type of surgery, thoracic, abdominal, orthopedic, okay, long-acting procedures, obesity, high level of anxiety as the pre-operative visit. All these factors I explained to you before. The risk intense post-operative pain is important when the score is 4 or more or 50. So you can apply this calcium pain prediction. It will give you rough estimation about the possibility of developing chronic post-operative pain syndrome. The next questionnaire, chronic post-operative pain can be controlled by conventional treatment modalities, by some pharmacological treatment. This is not true, as I said. It needs multimodal, multidisciplinary. So the most important is anticipation, prevention, and diagnosis. You have to anticipate from the type of the patient, the type of operation, the type of surgeon, as I said. You have to anticipate and try to prevent, and if it happens, you have to diagnose and go to the oral medication, physiotherapy, exercise, rehabilitation, behavioral medicine. You can do corrective surgery if the cause is obvious. You have to do your job as an anesthesiologist, diagnostic nerve block, therapeutic nerve blocks, and then the major intervention like implantable pain management device, neurostimulation, intrathecal pumps, and neuroablation. This is the control. This must be done at the same time if it is indicated. If from the start we have to put this one, try the start. Okay, it is not like a step ladder, not a step ladder. The medication with physiotherapy, the intervention must be done at the same time. This slide shows you some medications which act on the peripheral sensitization, like local anesthetic, topical, anticonvulsant, tricyclic opioids, central sensitization, anticonvulsants, opioids, lambda receptors, and descending modulation of inhibition pain, like anticonvulsants, opioids, and tricyclic antidepressants. The next 3 slides, I will summarize some of the most common post-chronic surgical pain syndrome, like post-thoracotomy pain, and this is the research and the studies about this syndrome. The incidence is 30 to 50% due to surgical incision itself, rib retraction, intercostal nerve injury, evidence with operative evoked motor potentials, trocar placement, chest tube placement, suturing technique, pericostal nerve injury, and rib fracture. So the post-thoracotomy syndrome, pain syndrome, may be neuropathic and may be nociceptive, may be due to muscle itself, muscle injury itself, and need Botox injection, for example, and the patient will be okay. Not every case needs intercostal nerve block and neuromodulation or neuroablation. The chronic post-surgery pain may be seen up to 50%. Post-mastectomy pain has 4 components. The patient may complain of phantom breast pain, like phantom post-amputation pain. Exactly. Intercostobrachial neuralgia, and it has a unique distribution and must be treated by sympathectomies and nerve blocks. Neuroma pain, the same treatment as intercostobrachial neuralgia and other nerve injury pain. This is the post-mastectomy pain, which is one of the famous post-surgical pain. After inguinal hernia is one of the most difficult cases in chronic post-surgical pain syndrome. But you have to notice the type of anesthesia has no effect, either spinal or general. There is no effect on persistent post-surgical pain. There are many factors. The type of surgery, it is laparoscopic versus open more. Nerve sectioning versus nerve identification. Some surgeons cut the nerve believing that if I cut the nerve, the syndrome will not happen. This is wrong because you injure the nerve. And the proximal end will send the impulses to the brain that there is pain. Recurrent hernias and use of and measured dissection and use of mesh will increase the incidence, and also the patients with pain, with higher pain sensitivity may develop this syndrome easily. And this is one of the most difficult cases I met. The take-home message, chronic pain syndrome following surgery are at least as difficult to treat as other neuropathic pain. Very important to prevent. Then palliation. Multimodal analgesia technique should be used in every surgical case to provide maximal analgesia with minimal side effect, and this is most likely to reduce the chance of developing chronic post-surgical pain. What we need? We need to design better clinical studies. Prospective, procedure-specific approach. We have to do study on post-thoracotomy pain syndrome. What are the causes and how to manage and how to prevent. To identification of all risk factors and include long-term follow-up. We need more awareness of chronic pain. Acute pain service team must be included in anesthetic process with regular education and training is very important, and thank you.
I would like to thank Professor Khaled for this lovely presentation.
Thank you.
Very fruitful, very thorough. We've got some questions. The first one is about nalbuphine and its use. So I think it's used as part of the management of acute pain.
About Perfusion?
No, nalbuphine.
Nalbuphine. Yeah.
Nalbuphine.
Yes. Yes, I agree to use nalbuphine as an opioid in treating acute post-operative pain, provided that the patient is not opioid tolerant. It is not an agonist, impure agonist. Is not like an oncologic patient on transdermal fentanyl patch or taking morphine tablets and then subjected to surgery. It is contraindicated to give him agonist antagonist like nalbuphine because he can develop withdrawal symptoms and lack of analgesia. So once nalbuphine is used, is only nalbuphine, no with other agonists.
So another question about ketamine and the dose of ketamine if used intraoperatively, and what's the ideal dose for the infusion?
Yes, we use sub-anesthetic dose about 0.5 to 1 milligram per kg by intravenous infusion over 1 hour.
And I may add to this, there's also some guidelines from the United States, yes. From the Society of Anaesthesiologists in the United States regarding ketamine. And I think these are the only guidelines present currently regarding the ketamine as a bolus and an infusion. There's also a question about chronic post-hernia repair pain. Yeah. What's the incidence and other interventional pain management for this type of pain?
The incidence about 30%, especially in recurrent cases and young patients, young age, from 30 to 40. I saw the most of cases at this age group. It's about 30 to 40%. It's very difficult to treat. My experience, as I said, I have to manage the origin of pain. So I examine the patient and examine the incision. Most of cases, I can feel neuroma along the incision. I can feel neuroma. If I feel this neuroma, I can inject corticosteroids around. This is the management of the origin of pain. Then we can do another blocks for the pathway of pain. We can do ilioinguinal or iliohypogastric or genitofemoral blocks or RF sonar guided if the distribution of pain with some of these nerves. And lastly, we can do sympathetic lumbar sympathetic block. As you know, the sympathetic nervous system is always work as pain generator in neuropathic pain because of sympathetic sprouting in neuromas. These neuromas that the surgeon creates in the nerve supply of this area now is innervated by sympathetic. So we can do sympathetic nerve block like lumbar sympathetic block in inguinal hernia, and we can inject steroids around the neuroma if you feel it, and we can do radio frequency or block for the offending nerve.
Okay, we'll take two more questions. The first one is about the role of magnesium in multimodal anesthesia or
it has a role, magnesium, because as I said, it is the lambda receptors will be open and working, and these lambda receptors share very much in the release of excitatory neurotransmitters. Why is lambda receptors is open? Because the magnesium plug closing these receptors will be will be expelled from these receptors, and so the receptors will be open. In giving magnesium, it will replenish these magnesium plugs and help too much in prevention of such pain.
And something also about the use of oral alpha-2 agonists in the preoperative period. So I think what the question means is that using alpha-2 agonists for some time before the surgery, not intraoperatively or just as a preemptive just before the skin incision.
Unfortunately, now in Egypt, we have no clonidine. Since 30 years or 20 years, clonidine was present in Egypt. Now it is not present. We can use it in the preoperative period. It is an antihypertensive drug. We can use it in the preoperative period as part of preventive analgesia. In Egypt, we have catapres, but we have no vials of clonidine to be put in intrathecal or epidural pathway.
If I may answer that from basically from experience, the problem with the clonidine that I've seen is hypertension, which is very exaggerated in elderly patients, and also lost in the recovery period, which can last for some time. And we always have this problem, like patients cannot go back to the ward, or the recovery nurses doesn't want to send them back to the ward because of the blood pressure is low. And there's some evidence that actually low blood pressure affects elderly patients more than others, and can cause an increase in mortality and morbidity. So I'll be very cautious regarding the use of clonidine. I think we'll stop the questions at this point. Thank you very much, Professor Khalid, for this lovely presentation and lecture. Have we got Dr. Ahmed Hassanin with us?
Yes, I'm here.
Brilliant, Dr. Ahmed. So I would like to present our second speaker for today, Dr. Ahmed Hassanin, Assistant Professor of Anesthesia and Critical Care Medicine in Cairo University. Dr. Hassanin is also certified consultant of anesthesia and critical care medicine in Saudi Arabia and Kuwait. In addition to that, he's a holder of the European Diploma of Anesthesia and Intensive Care Medicine. He practiced anesthesia and intensive care medicine in 5 countries, and I presume different continents as well. Dr. Hassanein has 55 international publications and also reviewer from multiple international journals. His main research interest is critical care and hemodynamic monitoring. Dr. Hassanein will talk to us today about monitoring of tissue perfusion in shock. And without any further ado, I would like to give the microphone to Dr. Hassanein.
Thank you, and Assalamu alaikum wa rahmatullah.
Alaikum salam.
I will talk about monitoring of tissue perfusion in shock. I will start by revising the of septic shock according to their last definition on JAMA on 2016. The sepsis 3 definition was hypotension requiring vasopressor therapy to maintain mean blood pressure at 65 and having a serum lactate greater than 2 after adequate fluid resuscitation. So we have 3 components should be present to say that this patient is in shock. Hypotension, serum lactate is elevated after fluid resuscitation. If we have an example for this case, a patient presented to the ER with this surgical abdomen. The mean blood pressure was 45, capillary refill time 8 seconds, lactate 0.5. Is this patient in septic shock? The answer is no.
I'm not sure, Dr. Saad, is it me or is it the whole thing has stalled?
No voice.
Have we lost the voice, I think?
We have now 2 components, impaired perfusion and mean blood pressure 45. If we give this patient 1.5 milliliters liters crystalloids and the mean blood pressure became 65, is there a problem in my internet?
Yes, I think, I don't know which slide you've got right now, Dr. Hassanein. Is it case A?
No, I am in case B.
No, I think it stopped at case A. So I think you just need to stop the sharing and start sharing again.
I am present now with you. Do you hear me?
Yes, that's right now. Yes.
Okay. I think it is a problem with the net. Case B is the same case. Mean blood pressure is low, capillary refill time is 10, lactate is elevated. Is this patient in septic shock? The answer is maybe. Why I said maybe? Because we have now 2 components, not 3. We have low blood pressure and we have elevated lactate, but we didn't examine the response to fluids. If this patient received 1.5 liters and the mean blood pressure became 65, so this patient is not in septic because we didn't fulfill the 3 components of the definition. Case C is the same patient, mean blood pressure 45, capillary refill time 10 seconds, lactate 3.5, received crystalloids, but the mean blood pressure is still low, and we needed norepinephrine to initiate to maintain the blood pressure. Is this patient in septic shock? The answer is yes. Why? Because we fulfilled the 3 components of the definition: hypotension requiring vasopressor therapy, serum lactate greater than 2 after adequate fluid resuscitation. The surviving sepsis campaign bundle, which was developed in 2018, developed an 1-hour bundle. It contained many components: measure lactate level, obtain blood cultures, administer broad spectrum antibiotics, and administer 30 milliliters per kg crystalloid, although this component was removed in the 2020 guidelines, and apply vasopressors. When we observe these recommendations, we will find that measuring the lactate level is the first step to define shock. So if the previous patient in the OR had mean blood pressure 65, capillary refill time increased to be 12 seconds, lactate increased to 4.5, although we have a normal mean blood pressure or accepted mean blood pressure now, we should increase the norepinephrine dose because we have impaired peripheral perfusion. Post-operatively, if this patient had a gangrenous colon and did resection anastomosis and was admitted to the ICU with mean blood pressure 65, capillary fill time decreased to be 6 seconds, the lactate decreased from 4.5 to 3, and we are on or norepinephrine infusion. What is the next step? The next step is to take your coffee. Why I said this? Because when the peripheral perfusion improves, when the capillary refill time improves and the lactate improves, you are doing the right management, and now you can have a rest. The message from the previous story is impaired tissue perfusion is the cornerstone in definition of septic shock. What about other types of shock? Is septic shock only the one which need elevated lactate to be defined? No. In this review article by Jean-Louis Vincent and Daniel Dubaquer, where the vice presidents of the European Society of Intensive Care, it was published in New England Journal of Medicine. When they define circulatory shock, the first step is there hypotension or no. After this, the second step, signs of tissue hypoperfusion. If the sign of tissue hypoperfusion is absent, so this is not shock. This is chronic hypotension or syncope. If there is hypoperfusion, so this is a circulatory shock, and you can go further to manage this patient. What are the basic steps of management of shock? As we said, the 1 hour bundle is the first step, initial resuscitation, then echocardiography to determine the cardiac output, then determine the fluid responsiveness to see whether your patient will need fluids or not, and the last and the important step is to determine perfusion indices. This is the importance of our subject today. What are the physiological consequences of fluid administration? When we give a patient fluids, the mean systemic pressure increase, cardiac output increase, and mean blood pressure, then the microcirculation will have increased flow, then there will be oxygen availability to the tissues, then there will be aerobic metabolism and organ function. These are the steps from starting fluid administration till reaching organ function. When there is shock, one of these steps is disturbed. For example, if we have capillary leak or vasodilation, the mean systemic film pressure will decrease. If we have hypovolemic shock or preload unresponsiveness, the cardiac output and the mean blood pressure will decrease. If we have microcirculatory dysfunction or edema or hemodilution, this means that we have an impairment of tissue perfusion. Then we have the last step is mitochondrial dysfunction. It will affect the oxygen availability and the aerobic metabolism. If we tested the circle, preload responsiveness and the fluid responsiveness, we will determine one stage of the shock. And if we determine this circle, this will be the main core of our topic today, which is peripheral perfusion. Peripheral perfusion, we need to evaluate one of these 4 steps. Organ function is the first one, aerobic metabolism is the second one, oxygen availability is the third one, microcirculatory flow is the 4th one. So perfusion indices will evaluate one of these 4 steps. How will we evaluate organ function? Through clinical evaluation of organ function. How will we evaluate aerobic metabolism? Through markers of aerobic metabolism. How will we evaluate oxygen availability? Through markers of oxygen delivery. How will we evaluate microcirculatory flow? Through markers of peripheral perfusion. I will take the first step, which is clinical evaluation of organ function. A clinical evaluation of organ function, such as CNS, if the patient is disoriented or drowsy, this will denote that there is impaired perfusion. If we have the diminished urine output, this may denote that we have impaired perfusion. But is oliguria a good perfusion index? The kidney receives 25% of the cardiac output and extracts a low amount. Thus, it can tolerate cold ischemia. Renal blood flow is preserved and even increased in septic shock. Acute kidney injury in septic shock is mainly due intrarenal microcirculatory abnormalities and not due to global hypoperfusion. Oliguria is a non-specific symptom which can be present in mild dehydration endocrine pathology after surgery. So the answer of this question is oliguria a good perfusion index? No, we should not rely on oliguria to say that our patient is perfused or not perfused. The second step is markers of aerobic metabolism. The most famous marker is serum lactate. Serum lactate is the gold standard of definition of shock. In this study in critical care medicine, they found that serum lactate is associated with mortality in severe sepsis. If we look about at this result, we will find that the lower lactate level has lower mortality and the higher lactate level has higher mortality. And in this figure, we will see that whenever the lactate increases, there is increased mortality. Not only the lactate, but also the change in lactate with resuscitation. In this study, they evaluated the change in lactate after cardiac arrest, and they found that in the in the survivors, the lactate decreased more than the non-survivors. So if I followed my patient and found that lactate is decreasing, this will tell me that my patient is better. Their conclusion was that lactate clearance is predictive of overall mortality rate in critically ill patients. Now the question, is serum lactate the ideal measure of tissue perfusion? This was answered in this review article by Jan Bakker, which is a famous scientist in peripheral perfusion. He is from Netherlands. They found that they put this algorithm which starts with elevated lactate. If we look at this algorithm, we found the first step after finding an elevated lactate is to see possible cause of increased lactate other than sepsis, which means that we have other causes of increased lactate such as seizures, liver ischemia, diabetic ketoacidosis, some medications. All these causes can increase lactate and can deceive us and give us a false impression that the patient has shock. So in this study, the same scientist, Jan Bakker, and another famous one is Glenn Hernandez, in Annals of Intensive Care, they found that after 24 hours of admission, the serum lactate remained elevated in 50% in patients who survived. So after 24 hours, if I found the lactate is elevated, this doesn't mean that my patient will die. 50%, as shown in the figure at the right, 50% of the patients after 24 hours have elevated lactate and will not die. In the same study, the scientists found that other perfusion indices such as capillary refill time and CO2 gap were normalized within 6 hours in surviving patients. So the answer of our question, is serum lactate the ideal measure of tissue perfusion? The answer is serum lactate still now is the standard perfusion index. However, it has the following limitations. Number one, it can be elevated in conditions other than shock. It is slowly normalized, and its follow-up requires frequent blood sampling. This should be taken in consideration. When I have a measure which needs frequent blood sampling, this is invasive and this is expensive to my patient, especially if we are talking in resource-limited settings. Now, after the markers of aerobic metabolism, which is lactate, the markers of oxygen delivery, global and local. I will talk in the first about global markers of oxygen delivery. Oxygen delivery has 3 components, as all of us know, hemoglobin and saturation and cardiac output. These are the 3 major determinants of oxygen delivery. These determinants lead to oxygen delivery to the tissues, and the tissues use oxygen and produce CO2 and some oxygen return back in the venous blood, which is the oxygen saturation. So I have at the end venous oxygen saturation and venous CO2. If I took the venous oxygen saturation and talk about it as a perfusion index, I will have an explanation of this with if I have an agricultural land and I have a canal which deliver water to the land, and another canal which takes the waste from the land. If I found that the drain or the waste is too much, this will denote that the land is well perfused. But if I found that the draining canal is empty, this means that the land is very thirst because it took all the water and didn't leave anything. The same will be applied to the venous oxygen saturation. If I found the oxygen saturation in the venous blood too low, this means that the tissues took most of the oxygen which was delivered by the artery. But if I found that the oxygen saturation in the venous blood is high, this will mean that the tissue did not take all of the oxygen. This means that the tissues are relatively well perfused. Now I finish the oxygen, the central venous saturation, I will talk about the CO2, the venous CO2 gap. What is the venous CO2 gap? It has another story to describe its importance. If I went to a metro station and I found that the metro is empty and the station is empty, this means that the metros come every 5 or 6 minutes. But if I found that the station and the train is full of passengers, this means that the train come every 1 or 2 hours. I mean that when the frequency of the trains are higher, the passengers will be drained and I will find less amount of passengers in the station and in the train. The same could be applied on the CO2 in tissues. When the tissue produces CO2, it should be drained by the blood flow. If I have stagnation in blood flow due to shock or respiratory or circulatory failure, this will lead to stagnation of CO2 in the tissue and increased CO2 in the venous blood. This will widen the gap between the venous CO2 and the arterial CO2. The gap between the venous and the arterial CO2 is normally less than 6 millimeters mercury. If it was increased above 6 millimeters mercury, this can denote that the patient is hypoperfused. And this was proved in the following study. This study by John Whitbull and other colleagues, they took 10 patients with cardiogenic shock and they delivered dobutamine infusion and measured the cardiac index and the CO2 gap. They found that whenever the dobutamine dose increased and the cardiac output increased, as in the left figure, the CO2 gap decreased as in the right figure. So if there is correlation between the CO2 gap and the cardiac output. About the central and mixed venous saturation, in this study at critical care 2006 and 6, we will find that in the patients of complication with intra or post-operative surgical complication, the lower central venous saturation is associated with complications, the higher central venous saturation. And the conclusion was that the post-operative complications are more in the patients with low venous oxygen saturation. Our question now, are the CO2 gap and the central venous saturation the ideal measures of tissue perfusion? The answer is both measures are good indicators for perfusion. However, they have these limitations. They need frequent blood sampling. If I want to measure the CO2 gap, I should take arterial and venous samples at the same time, and this is expensive and invasive, and cannot be repeated every now and then because this is too much. This will lead to too much cost. Also, the high central venous saturation does not exclude shock. So till now, we didn't reach the ideal measure for peripheral perfusion, although all these measures are useful and can be combined together. I finished the global markers of oxygen delivery. We have local markers of oxygen delivery in certain organs, such as the renin. All of us know that the renin and angiotensin is the axis, one of the axes that control blood pressure. When the blood pressure decreases, the kidney perfusion decreases, and the kidney produces renin to increase the level of angiotensin and make vasoconstriction to elevate the blood pressure. So if I found the renin elevated in a patient, this means that his kidney is not well perfused. And this was proved the last year in a study in critical care medicine. They compared the lactate and the renin and found that renin was more accurate than lactate in following up the patient. But this is one study, it was not replicated yet in other studies, and renin is not really available in the market for measure. It is only used for research purpose. But in the next few years, if it proves that if it was proved that it is better than lactate, we may use it in our clinical practice. Other measures of oxygen delivery are present, such as near-infrared spectroscopy and such as transcutaneous pressure of oxygen, but these measures need expensive devices and are not readily available in our country. The last part of our lecture is the markers of perfusion, peripheral perfusion in non-vital organs. Why I say non-vital organs? Non-vital organs deteriorate earlier and it recovers later than vital organs in circulatory failure. In other words, the shocked body would sacrifice the skin and the skeletal muscles first before sacrificing more vital organs such as the heart and the brain. So when I found that the skin is cold and there is mottling and there is delayed capillary refill, this may be present in a shocked patient before hypotension and before elevation of lactate. In this study or this case report in New England Journal of Medicine, this is a patient of cardiogenic shock in the left side. You will see that the skin is mottled, and after 24 hours of resuscitation, the skin returned back to the normal color. So skin mottling is a very clear sign of hypoperfusion. In this study, a French group found that a mottling score can predict the survival in septic shock. They made the score according to the area which is mottled in the skin. And they found that if the score was low, this will have good survival. When the score increases, there will be a rapid death than when there is no mottling. They found also that increased mottling is associated with lower urine output, higher lactate, and higher SOFA score. The same group found that the decreased skin perfusion using the laser Doppler, and another group used the thermal camera and found that the mottling score reflects the perfusion of the skin. The second peripheral perfusion index, which I will talk about after the mottling score, is the capillary refill time. Capillary refill time is simply done by firm pressure on the distal phalanx for 5 seconds and recording the time to return the normal color. The upper limit of normality is 2 to 3 seconds. The same French group which studies the mottling score did this study where they found that when they compared the survivors and the non-survivors in shocked patients, in septic shock patients, they found that the capillary refill time is higher in the non-survivors. It is 5.6 seconds, while it is 2.3 seconds in the survivors at the index and the knee also. It can be done at the index and the knee. They found also that the survivors has lower capillary fill time after 6 hours compared to the non-survivors. Another measure is the perfusion index, which is measured by the pulse oximeter. It is the ratio between the pulsatile and the non-pulsatile portion of peripheral circulation. When there is vasodilatation, the pulsatile portion will increase and the perfusion index will increase. When there is vasoconstriction, which is a state in shock, the perfusion index will decrease because of peripheral vasoconstriction. In this study, the perfusion index was measured in patients in critically ill patients, and they found that the survivors, when there is impaired perfusion in T1, the perfusion index was all. That means that the lower perfusion index are you hearing me? Hello?
Yes, yes, we hear you.
Ah,
Dr. Prof.
Yes.
Because
we can
I
hear
have a signal that the internet is weak.
Is-
I'm confirming that my sound is clear.
It keeps dropping, but it is all right. You know.
Okay, okay. In this study, it was performed in our university, in Cairo University, and I was one of the authors of this study. We evaluated the perfusion index in patients with septic shock, and we found that if the perfusion index was less than 0.3, it predicted that this patient will need vasopressors. And if the perfusion index was less than 0.2, this predicts mortality. This was published in Shock in 2015. Now the question, is perfusion index an ideal measure for tissue perfusion? The answer is perfusion index is non-invasive, useful measure and give a continuous reading. And it is a real-time measure, which is an advantage over all the previous measures. However, its main drawback is the wide variability of the baseline values. We don't know what is the normal perfusion index. One person may have perfusion index of 5, and another person can have a perfusion index of 3 or 2, and both are normal. So it is better to be used for follow-up. Now we will move to the temperature gradient. This study was published in Circulation in 1969. They measured the temperature of the two in shocked patients, and they found that when the cardiac index increased and the mean blood pressure increased, the two temperature increased and the lactate decreased. They also found that when any of these variables is reversed, all the other variables will be reversed in the same direction. When they did correlation between temperature and cardiac index, they found that there is a positive correlation between both variables, and they also derived an equation to calculate the cardiac index from the two temperature. Also, they found that the lower two temperature is accompanied with this. More recently, other temperature measures were used, such as the forearm to fingertip skin temperature and the central to two temperature difference. Both measures are more accurate than the single reading of the two temperature because they will not be affected by the ambient room temperature. This is another measure which is to room temperature. When the gradient between the two temperature and the ambient room temperature increase, this can predict poor prognosis. So if I finish now the peripheral perfusion indices, which are the mottling and the temperature gradient and the perfusion index and the capillary refill time. Now we have metabolic indices and the peripheral perfusion indices. Which is better? This was answered in this review by the same group which done most of the previous studies. They found that the traditional markers of tissue perfusion may not be readily available, such as the lactate, and may take time to assess, such as the urine output, while the skin is easily accessible organs and can be evaluated more frequently, and it is more economic and earlier to be discovered than other measures. Why are the peripheral perfusion indices better than the global indices? In this famous study, which is one of the most important studies which will change the practice of medicine, it is called Andromeda Shock randomized trial. It was published in JAMA last year. They found that they compared the lactate guided therapy and the capillary refill time guided therapy, and the first analysis found that no difference. So if you use capillary refill to guide the therapy of your patient, it will not be worse than using serum lactate. The results of this study were then reanalyzed and published in the American Journal of Critical Care Medicine, and they found that peripheral perfusion targeted resuscitation, I mean the capillary refill time, resulted in lower mortality and faster resolution of organ dysfunction when compared to lactate targeted resuscitation strategy. The same study was reanalyzed and published in Intensive Care Medicine as a letter, and they found that the capillary refill time not only improved the outcome, but also it can detect the phenotype of the shock. If the capillary refill time was normal, even if the lactate is high, this means that this shock is not severe and this patient have a high rate of survival. Also, the capillary refill time has the advantage of detecting what is called hemodynamic coherence. In this review article, this is a diagram describing what is meant by hemodynamic coherence. Preserved hemodynamic coherence means that there is a coherence between the macro circulation, which is blood pressure, and the macro circulation variables, and the micro circulations at the tissue level. If I don't have this coherence, I will give fluids and there will be a capillary leak. So there will be a dissociation between the macro circulation and the micro circulation. I will improve the blood pressure and the feeling pressures of the patient, but this will not improve the peripheral perfusion. The capillary refill time has the advantage of detecting the hemodynamic coherence, and it has rapid kinetics and correlated with deep hypoperfusion markers. Also, capillary refill time can it is associated with deep hypoperfusion markers. Why are the peripheral indices better than global indices? The capillary refill time is more dynamic than the serum lactate, so it can be followed up at shorter intervals. As I said previously, the serum lactate may remain elevated for 24 hours in 50% of the patients. The capillary refill time can detect hemodynamic coherence. The capillary refill time also can identify the shock phenotype. And finally, the capillary refill time is simple, economic, repeatable, and non-invasive. Now, if we revise the basic steps of management of shock, we will find that our steps are initial resuscitation, echocardiography, fluid responsiveness, and perfusion indices. Don't forget, when you revise the perfusion indices, you should revise the patient for the adverse effect of fluid resuscitation. You should maintain the perfusion of your tissues, and you should also confirm that the fluids will not harm your patient. What are the adverse effects? Lung congestion, hemodilution and coagulopathy, right ventricular dysfunction, and increased intra-abdominal pressure. All these signs should be clearly, closely monitored when we are resuscitating our patient. So if I have fluid infusion, I need to see whether my fluid infusion is effective or not through the oxygenation indices and the cardiac output and the preload indices. And I will need also to see whether my fluid exerted adverse effects or no, such as lung edema, hemodilution, right ventricular dysfunction, and intra-abdominal pressure. This review article was published by our group, and it summarized all the perfusion indices. It will be a very useful reference, and I summarized in it all the perfusion indices, and everyone with its advantage and disadvantage. I hope it will be helpful for everyone to revise all the previous data. The summary is poor perfusion equals shock. I will never say this patient is shocked except if I have poor perfusion. Persistent poor perfusion equal poor outcomes. Perfusion indices include anaerobic metabolism indices such as lactate, or indices for oxygen delivery such as central venous saturation, and peripheral perfusion to non-vital organs such as temperature gradients, skin mottling, and capillary refill. And these are the best perfusion indices. Lactate is still the gold standard. However, it has important limitations. I already discussed it. Every measure has pros and cons. So it is essential for every anesthesiologist and the critical care physician to know all the indices and the limitation of everyone, to choose according to the situation and the resources in the hospital. The capillary refill time is a simple measure for perfusion indices, and it has many other benefits such as detecting hemodynamic incoherence. And finally, don't forget to monitor the adverse effects of fluids such as lung edema, oxygenation, intra-abdominal pressure increase, and hemodilution. And thank you.
Thank you very much for this lovely lecture, Dr. Hassanein.
Thank you.
I've got some questions. The first one: does sudden acute drop in end-tidal CO2 is good indicator for lung hypoperfusion without any change in ventilatory settings?
Yes, the answer is yes. CO2, if the end-tidal CO2 was decreased, this may denote that the cardiac output is decreased, but we should confirm that there is no ventilatory problem or chest problem. And in my practice, when I see an end-tidal CO2 suddenly became 25 or 20, I usually predict that the following blood pressure reading will be low. This is right.
Brilliant. Regarding renin and its use to diagnose hypoperfusion, is a daily level satisfactory? Or do we have to do it more often?
Till now, the serum renin is under investigation. There is only 1 or 2 studies on it, so its use was not yet implemented. Even the normal values are not known. We are going to see, there is an ongoing thesis in our university. We are examining renin in septic shock patients, but we still didn't have results yet. So I can't answer this question. This question, I think, will be answered in the next few years when more studies evaluate this marker.
Okay. We've got 2 questions. I think they're both the same regarding the capillary fill time, because it is very subjective to measure. So what do you think is the best way to measure it?
Yes, I agree with this question. The problem with capillary refill was previously said that if I pressed on the capillary refill time, my pressure will be different than your pressure, than another one pressure of the male will be different than the female. And they, in some studies, but I didn't go further in these studies because the time is limited, they invented a device which make a standard pressure so that to compare, to be able to compare patients with each other. But this is not, we like the capillary fill time because it's simple. If it was.
Sorry, we can't hear you. I think we've lost you. I think it's the internet connection. Can you repeat that again?
Connection. Hello.
Yeah.
Yes, I am here. Am I here now?
Yes.
Am I here now?
Yeah, we can hear you now. So can you repeat that, please?
Okay. Some scientists invented a device to measure the capillary fill time, to make a pressure standard pressure. But this device will be complicated and will make the measurement not feasible in every hospital. So there is another assumption which is making a firm pressure with your finger as a doctor till your finger is white. If your nail became white, this means that there is no perfusion in the finger of the patient. And then you release your finger and count the seconds by a stopwatch. It is very simple. The problem was in how much pressure should I apply. But measuring the refill time is not so difficult, especially when we know that the lower limit is 2 to 3 seconds. So any number above this number, 5, 6, 7, 8, 10, 12, it will be prolonged. It is not necessary to know exactly what is the number.
Okay. Also, we have another question. What is more dependent for perfusion indices, lactate or capillary fill time or mean blood pressure? I think we've answered that during the presentation, is that the capillary fill time is kind of more...
is the best. the serum lactate is still the standard in the definition and in the guidelines. But I think that the capillary refill will be introduced recently because the large study of JAMA is published last year, so its consequences are not yet implemented in the guidelines. The mean blood pressure should never be used as perfusion index because the mean blood pressure, the normal differs between persons and each other, and I don't know whether this blood pressure is sufficient to the patient or not.
Okay. And lastly, it is not regarding hemodynamic monitoring, but I think it is very common questions. Question is the role of corticosteroids in septic shock.
According to the guidelines, hydrocortisone 200 milligrams per day divided on 3 or 4 doses are recommended in any septic shock patient if he was on vasopressors. This is the last evidence till now.
Yes, I have to say that I did my my master degree back in 2000 and 2009, and that was my essay question, and it's still the same, still no change since then. Still again for septic shock, unresponsive to vasopressors. Yes.
Now it was changed. In the 2012 guidelines, it was recommended if the patient is not responding to those vasopressors. Now it is recommended in any patient on vasopressors.
Vasopressors, yes.
Any patient, even if it's stable on vasopressor.
Brilliant. Any further questions? Any more questions? That's it. Brilliant. Actually, I've got a question, which is something. Last year, I attended kind of a workshop about artificial intelligence and the implementation of technology in healthcare. And there was a device. The company was promoting it, and it was about actually detecting blood pressure or hypertension intraoperatively, even before the patient blood pressure starts to drop. So about 10 minutes before the blood pressure starts to drop. And they looked at very various and multiple things in terms of some hemodynamic measurements or indices, and they looked at different things in terms of the monitor itself, blood pressure, heart rate, and they also analyzed the ECG, a lot of things. And they actually, using a lot of data, they could predict the hypertension 10 minutes before it happens. So I think in the future we might have something like that in the context of critical care and shock patient, where like they use a lot of indices and a lot of data to inform us about whether this patient will be responsive to vasopressors or whether they'll be responsive to fluids and how much and stuff like that. So maybe in 10 years time, it's going to be all done by a computer. All right, I would like to thank Professor Khalid and Dr. Sani for the lovely night tonight, and I hope that was useful for you all. It was useful for me, and I enjoyed it very much. I would like to thank the Mega Academy team and Dr. Sad specifically for his effort and dedication. I hope that it was a lovely night for you, all of you. Thank you very much.
Thank you. Thank you.
Thank you very much. Okay.
Thank you.
Thank you very much, everybody. Thank you very much, Prof. Khalid and Prof. Ahmed Hassanin. And a special thanks for Dr. Reedy. He's dedicating his time for moderating this session. And thanks for all our guests and Dr. Anna from Canada, Dr. Adil from Emirates, and other people from Egypt, Dr. Sahab Marzouk, and my colleague, Mega Organizer. A special thanks to Dr. Walid Aswa and Dr. Hisham Abdul Maqsood. Everybody is so proud by the structure and the function and success of the Mega online course. 2 excellent lectures tonight. I'm so proud. Couldn't be more proud than tonight. Thank you very much.
Thank you very much. Thank you.
Bye bye.